Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Today we are strapping in for a look at a difficult bleeding scenario, specifically Parastomal Variceal Bleeding, or PVB.
Our mission today is to really distill the technical necessities of percutaneous embolization. We'll be comparing techniques, things like Percutaneous Antegrade, Transhepatic Venous Obliteration, PATVO, against, the long-term control you get with the TIPS.
And we're going to dissect the hard data on recurrence. We need to understand why local treatment so often fails.
Exactly.
So to ground this, let's picture the clinical scenario. You've got a 47-year-old male, extensive metastatic rectal cancer, liver, lungs, the works. He has a diverting colostomy.
And he's bleeding.
He is bleeding. Catastrophic transfusion requiring stomal bleeding. And the crucial detail here is that he's already been evaluated and ruled out for a TIPS procedure because of that persistent metastatic disease.
And that's the decision point, right? That's critical for you, the attending. When a TIPS is off the table, the entire burden, everything, it shifts to that local occlusion procedure.
You have to get it right.
You have to maximize technical success on the first attempt because, while bleeding is rare in the general stoma population, maybe 5%, the incidence just explodes. It goes up to 25, even 50% in stoma patients who also have portal hypertension.
And the cost of failure is great. The reported mortality rate per bleeding episode is a terrifying 3 to 40%.
Right.
This is not a low-stakes bleed. This is life or death, made against a background of incredibly high portal pressures.
Okay, so before we get into the wires and the coils, let's really nail down the anatomy and the pathophysiology that we're up against.
Good idea.
Parastomal variceals are basically pathologically dilated mesenteric veins.
Yeah.
They form these spontaneous anastomoses, these shunts, right there at the stoma's mucocutaneous border.
So the high-pressure portal system is just trying to decompress itself. It's routing blood to the low-pressure systemic veins in the abdominal wall, and the stoma site just happens to be the path of least resistance.
Exactly. It's this aggressive portosystemic detour that we need to shut down, and I mean permanently.
And these shunts, they're not all the same, are they?
Not at all. The most common setup you'll see involves collaterals running alongside the inferior mesenteric vein, the IMV. But you also see variations coming off the SMV or even the splenic vein. The absolute key for your pre-procedural planning, which you're going to do with the venous phase CT or MR angio, is mapping the precise afferent and efferent vessels.
Because if you miss one branch,
it's a path to recurrence.
And the clinical presentation can be a real pitfall. We all learned the classic description, the raspberry appearance, the bluish discoloration, hyperkeratosis.
You almost never see it.
Well, it's only present in a minority of patients. The reality is many high-risk patients have really subtle findings right up until they start hemorrhaging.
Which is why relying on a physical exam alone is not ideal.
Yeah.
It's dangerous. The definitive confirmation of the anatomy and the specific bleeding source, that requires imaging.
So you need that roadmap.
You need the roadmap. We're talking venous phase contrast angiography or direct portal venography during the procedure.
Okay, so once that anatomy is locked down, we've got the management spectrum. For the acute bleed, the first reaction is usually conservative.
Right, local compression, maybe some epinephrine-soaked gauze. Then you've got medical management like beta blockers, maybe a local sclerotherapy injection.
But as an attending, these are just temporary fixes. They're associated with the highest rebleeding rates, especially when you're dealing with a massive portal pressure gradient like the one in our case.
And surgical options, stoma revision, ligation, they also have high recurrence rates. They just don't address the underlying portal hypertension.
Which brings us squarely to our world, the percutaneous IR options, PATVO or TIPS. But the crucial thing to realize is that even with these high-tech interventions, the overall rebleeding rate is still stubbornly high. It's anywhere from 0 to 50%.
And that huge variance is what makes the technical execution so critical.
So let's talk technique. That massive range in outcomes means the choice of approach direct percutaneous versus transhepatic is not arbitrary, right?
Not at all. It hinges entirely on the collateral vessel location you see on your initial CT map. If the variceal complex is localized, superficial, maybe direct percutaneous parastomal embolization will do the job.
But if you need robust proximal control.
If you need that proximal control of the main afferent vessels, especially those coming off the deep portal system, then the transhepatic route is really required.
Which is exactly what happened in this case. So let's walk through the exact steps for this transhepatic antegrade venous obliteration. It starts with access.
Right. So percutaneous transhepatic portal access. Typically, you'll use a 22-gauge Chiba needle targeting a right portal vein branch. It needs ultrasound, maybe combined ultrasound and fluoro guidance.
A key is stable access.
Stable access is everything. You need to be able to place your working sheath, a 6 French bright tip or something similar, that gives you max support and minimizes trauma to the liver capsule.
And right away, the pressure gradient confirms the challenge. The measured mean portal pressure was 33.
Yeah. That is a difficult pressure to embolize against. That kind of gradient creates resistance. It demands a really aggressive embolic technique to prevent immediate washout.
Absolutely.
So the subsequent main portal venogram confirms sluggish flow coming off the inferior mesenteric vein. That was clearly the source. We catheterized the IMV and revealed 3 distinct collaterals feeding the stomal bed.
3 of them.
Yep. 1 large superior vessel and 2 smaller inferior vessels, a lateral and a medial. And mapping all 3 is it's non-negotiable.
Okay, now for the artistry. 3 vessels, 33 millimeters of mercury. You can't just use a single agent here. This required a multimodal embolic cocktail. Let's start with those 2 inferior branches.
Okay, so those were the smaller ones, about 3 and 4 millimeters. The strategy there was primarily mechanical. We embolized them distally using detachable microcoils, specifically, emboled fiber coils.
Then you really pack them in?
You have to. The 4 millimeter medial branch got a combo of 5 by 8 and 4 by 8 centimeter coils to ensure dense packing. The smaller 3 millimeter lateral branch got a 3 by 6 centimeter coil. The goal is complete flow arrest well past the feeding trunk to stop any proximal recanalization.
And focusing on those coil sizes, using 5 millimeter coils in a 4 millimeter vessel, that suggests a really deliberate choice to maximize that packing density against that pressure. But the superior vessel, the 5 millimeter one, that was the main conduit. This is where the complexity really spikes.
It does. For a high flow, high pressure conduit like that, you need immediate confirmed stasis before you inject your sclerosing. That's why they use a Python balloon.
Right.
You inflate the balloon, which temporarily achieves proximal flow reduction. That allows you to deliver the chemical component, Gelfoam with STS.
Can you break down the specific components for us? Why Gelfoam, I think it was 4 cc's of sclerosant versus, say, something like glue and butyl cyanoacrylate.
Yeah, that's a critical trade-off. Glue offers, faster polymerization. It's excellent for rapid definitive occlusion, but it lacks forgiveness and has a higher risk profile for non-target embolization, maybe systemic toxicity, especially in this high-flow, wide-caliber vessel.
So the Gelfoam STS is a safer, more controlled approach.
It's a more controlled chemical approach.
Yeah.
The Gelfoam acts as the bulking agent and the carrier. It slows the flow. The STS, the sodium tetradecyl sulfate, that's the active sclerosant, it chemically induces thrombophlebitis and vessel wall injury, which leads to permanent occlusion.
So controlled chemical stasis is preferred, especially with the patient's systemic disease and comorbidities. After delivering the foam, they topped it off with a mechanical cap, a 6 millimeter micronestor pushable coil. What's the function of that coil after the chemical job is done?
It's the permanent barrier. It's the final anchor. It ensures that foam and sclerosant mixture stays trapped distally and doesn't wash out back into the portal system when you deflate the balloon.
Which could lead to non-target effects or just failure.
Or just rapid failure of the occlusion.
Exactly.
It's a staged occlusion. Mechanical restriction first, then chemical injury, and then a permanent mechanical cap to seal it off.
And the ultimate technical endpoint was confirmed on completion venography, showing complete stasis in that parastomal network, while, thankfully, preserving that essential hepatic pedal flow. It's just a demonstration of maximum effort when TIPS isn't on the table.
So the technical success of these procedures is phenomenal. In the literature, it's typically 88 to 100%. That means we can almost always visualize, catheterize, and get acute flow stoppage.
But the difficulty is the long game.
That's it. The Achilles heel is and remains the recurrence problem. And this is the data that has to influence your follow-up planning. Recurrence rates, even after a seemingly perfect PATVO, can soar up to 50% within the first year.
50%.
50%. And we have to really analyze why that is. Recurrence isn't usually caused by recanalization of the embolized vessel. The combined coil and foam approach is actually highly durable.
So what is it?
The dominant mechanism is the recruitment of new collateral vessels. The underlying portosystemic gradient hasn't changed. The body sees the embolized pathway as blocked, and it immediately reroutes that high pressure through a new pre-existing dormant systemic venous channel nearby.
I saw one successful case series where the median time to rebleeding was a shockingly short 45 days.
Yeah.
Which just confirms how aggressively the body fights a localized occlusion if the underlying pressure isn't addressed. Which, of course, brings us to the definitive data comparing embolization to doing a TIPS.
And this is really the crux of the decision matrix. A systematic review quantified the benefit of addressing the root cause, tip placement, by establishing a controlled shunt that normalizes that portosystemic gradient. It fundamentally treats the disease.
And that treatment translates into a reduction in recurrence risk by, what was it? A remarkable 78.5%.
A staggering number.
It is a staggering number, especially when you juxtapose it against the, roughly 50% recurrence risk following localized percutaneous embolization alone. PATVO treats the symptom, the bleeding varix, but TIPS treats the cause, the portal hypertension.
Precisely. And if you look at the case series outcomes, 100% technical success, 82.3% early clinical success, the initial metrics look great.
Right.
But the 6 and 12-month rebleed rates were both 20%. And that led to the necessity of either a repeat procedure or eventually conversion to TIPS. The embolization is essentially buying you time, but it's rarely a long-term solution on its own.
So for the IR attending, the decision framework solidifies. TIPS is the most effective long-term therapy, but PATVO has to remain the preferred first-line therapy.
Absolutely.
You use it to control the immediate hemorrhage in a patient who might have limitations like significant hepatic tumor burden or severe comorbidities that just contraindicate a TIPS placement. It's a risk-benefit calculation, and it's weighted heavily toward avoiding the morbidity of TIPS unless you absolutely have to do it.
And the technical low-risk profile of embolization supports this approach.
Yeah.
The complications for PATVO are generally minor. You're talking local issues like parastomal skin ulcers, maybe a transient worsening of renal function.
Nothing major.
Right. Major complications like non-target embolization are really uncommon with proper technique. And importantly, there are no absolute contraindications to PATVO, just relative ones like severe coagulopathy. It's safe enough to try first.
The lesson is clear then. PATVO provides immediate control with low procedural risk, but you have to aggressively manage that follow-up. You have to know that the pressure gradient is working to recruit new shunts.
So to sum up, we've established that for complex, high-pressure parastomal bleeds where a TIPS is initially restricted, the transhepatic approach combined with an aggressive, staged embolic technique coil, chemical sclerosant, mechanical cap, that is the required standard to ensure immediate complete stasis across all the afferent vessels.
And the knowledge synthesis for you, the listener, is that PTVO is your highly effective first-line weapon for acute control. It buys you time, it avoids the systemic impact of TIPS, but you have to approach that patient with the high potential for recurrence, that 50% risk front of mind. That has to drive the need for robust, early clinical follow-up.
And let's end with a provocative thought, one that sort of challenges the current second-line consensus.
Yeah.
We reviewed data showing patients who died from catastrophic hemorrhagic shock on the day of intervention, despite attempts at local embolization.
Yeah.
So given the immediacy and the fatality of those acute bleeds, where do you draw the line on TIPS candidacy for a patient with acute, life-threatening parastomal bleed, even if their oncologic prognosis is poor?
That's a heavy question. If the only intervention that offers a nearly 80% recurrence reduction is a TIPS, is there an acute scenario where a palliative TIPS is technically justified just to achieve immediate life-saving hemorrhage control, regardless of hepatic tumor burden?
It forces us to reconsider the timing, the selection criteria for moving from embolization failure to an urgent palliative TIPS when the mortality risk is that immediate and that high.
It's a question of prioritizing catastrophic hemorrhagic control over, maximizing oncological freedom.
This is Dr. Rusty Hoffman, and that's a wrap from Wisdom Radio. Find cutting-edge insights through our rapid-fire videos and community forum at medicalwisdom.ai. And remember, knowledge is the best medicine.